Today's conversation is all about the boobies. That's right, it's October and we are talking boobies. If you've never watched my podcast before, I am begging you to watch this one because if you have boobies, if you love somebody with boobies, and gentlemen, even for you, it affects all of us. My guest is Sherry Goldman, and Sherry is a nurse practitioner at the Cedars-Sinai Breast Center. She's giving us all the tips we need to fight breast cancer like a girl.
Hey baby, it's time for the NIKKI ALPERT Podcast. Come on, pull up a chair. We gonna have some fun.
Hi everybody and welcome back to the podcast. My very special guest today is Sherry Goldman. Hi Sherry, how are you?
Hi Nick, how are you?
It's good to see you. I have been talking to Sherry about my boobies and other people's boobies for years. And being that it's Breast Cancer Awareness Month, we decided to have our conversation about boobies now. So Sherry has been in the medical world taking care of women's health for 40 years. She's a nurse practitioner at Cedars-Sinai right here in Los Angeles, and she works in the brand new breast center. She's been honored by Cedars with the Presidential Award, and she also represents them on the National Breast Cancer Coalition Board. And again, she's being honored by that board this year at their annual fundraiser for being an outstanding advocate. And more about Sherry, she's a professor at UCLA, an associate professor. She has spoken all over the world about boobies, and she mentors nurses all over the world. And she's also the co-author of a book called Breast Cancer 101, which she shares with her patients. And most importantly, after finding a lump while doing a self-breast exam, Sherry is a 20-year breast cancer thriver. Sherry Goldman, welcome to the NIKKI ALPERT Podcast, and welcome to my virtual chair.
Thank you. I am going to correct one thing you said.
Please.
The breast center is new in that it's redone,
Okay.
But it's been there for a little while. We've probably been there 10 years, but we moved out for 2 years and now it's brand new. So you're
Nice.
absolutely right.
Okay. Well, and also I've been there, so I knew it wasn't brand spanking new, but I've been there with friends who had to come to you and all of that. So, and
Yeah.
it's beautiful inside too.
Yeah, it looks like a rocket ship.
It does. It does.
I know.
Okay, so we talked about what we were going to discuss, but I have one question for you that I didn't ask. And why do you call yourself a breast cancer thriver instead of a survivor?
Oh, that's an interesting question because I think survivor is a hard name. And several other people started calling themselves a thriver. So I am thriving as a breast cancer survivor.
Okay.
Sometimes surviving doesn't mean that. And most women do thrive, hopefully, after they are diagnosed.
So we like thriver better because that means
Yeah, we do.
That's good. All right. I like that. All right. So we're just going to jump into it because being that you're the big cheese in the boob market, I really just have so many questions to ask you because the information out there is daunting. And
It is.
It is. And now that we all have access to the web, you just go down that rabbit hole and you get terrified. So let's start with this. Should we all be terrified? Like, are we all at a terrible risk for this, for breast cancer?
No, I mean, it's a terrible risk because everybody talks about it. I started in this field it's almost 30 years now. And I can remember that when I worked with Susan Love, who's one of the mavens of breast cancer, we actually put a sign up called the Breast Center. And it was so new about saying breast and cancer that one of the doctors tore it down because it had breast on it. I'm not kidding you. I kid you not. And we laughed and thought, my gosh, this guy's so old fashioned and so forth and so on. But I think there's so many myths out there about breast cancer that's what makes it scary is because once people started talking about it, it was like, where's the science? And that's what I'm into is where's the science?
I'm going to go with you down the science route instead of not the science route. I mean, seriously. Okay, well, speaking about the myths, I mean, there is so much to be said. And I guess people just make up stuff about why they think they got it and then it spreads even further. Like
Exactly.
So let's talk about the science of what puts us at risk. Is that a good place to start, you think?
That's fine.
Okay.
So every woman is at risk, okay? And
because we have boobs?
Exactly. Just
Okay.
because you have breasts and you have hormones.
Okay.
So the highest risk for getting breast cancer is being a woman. although men do get it, but not
Right.
very many, not very many. Second highest risk is age. The older you get, the higher your risk. And the average age of breast cancer is about 62 years old.
Okay, I didn't know that.
Yeah, that's the average age. When they give you numbers like 1 in 8 or 1 in 6 or whatever the number they come up with, let me ask you a question.
Okay.
So what do you think that means if I say to you, Nikki, you have a 1 in 8 chance of getting breast cancer? What do you think it means?
Okay, well, I've been hearing that number, and I think it was 1 in 6, like you said a minute ago. I remember hearing it in 8th grade and sitting down with my group of girls. There were 6 of us. We called ourselves, it was an acronym. It was Elsie Lakanika. And there were 6 of us. And there were the first letters of our names. And we knew that 1 in 6 people, women, got breast cancer. So we thought that at some point in our life, one of us 6 would get breast cancer. So it seems to me that I think one group in every 8 women. Does it not mean that? Or 6 women?
Well, what it actually means is you have a 1 in 8 chance of getting breast cancer in your lifetime. So now it's not 1 in 8 in this year or in 6 women or next year. It means over a lifetime, everybody has about a 12% chance of getting with no risk factors, getting breast cancer without any risk factors. But when you have risks, then your risk goes slightly up. And those kind of risks are family history, getting older, taking hormones, exposures. There's so many risks, but exposures to
what?
To the outside, to radiation, to, there's I could go on the whole podcast about what the risks are, but it's really important that you look at that and know what your risks are. And most important is family history. Now, what does family history mean? Does your great aunt that had breast cancer, does that mean you're at higher risk? Not necessarily.
The closer they are to you, right?
Pardon?
The closer. Okay.
Yes. Yeah. So if your mom had breast cancer and she had it premenopausally, you jump up in risk. Not to 100%, not to even 20%, but probably, and I'm eyeballing this right now. I'm not a geneticist, but I've worked with enough that I kind of know. So if you have a mom with breast cancer that's diagnosed before menopause, you probably have about 15, 16 chance of getting breast cancer in a lifetime, because that added to it. Does that mean you're going to get it? No, that still means you have more than 80% chance of not getting it.
Right.
But when you add a whole lot of risks together, then you start looking at things like scales that the medical profession has that we look at, and we can figure out exactly what your number is. Geneticists are big at Cedars in doing that. They take family history into concern, exposures, DES.
What's DES?
As I said, DES is a diethylate stilbestrate, which I can never say right. Women took it to prevent miscarriage.
Oh, I remember hearing about that drug.
Yes,
okay.
Exactly. So there is a theory that may put you at higher risk for breast cancer, but how much higher risk? 1%? So if you have that's your only percentile, and then you have an average of 12%, okay, maybe you have 13.
Right.
So it takes really going and finding out what your risk is.
So does somebody give you your number that you what's the name of that number that you label people risk-wise? Is there a name for that?
It depends upon the kind of test you have. There's a Tyrer-Cuzick test, there's a Gale model test, and they all have different criteria. So it's this, even in science, this is kind of a different sort of thing that we're talking about here, because they add them all up together.
Okay.
Now, if you have, like, for example, I have a patient right now who has 5 sisters with breast cancer, all premenopausal, and the mother was never diagnosed.
Interesting.
Now, that puts her at higher risk, doesn't it?
Yeah, because the sisters are very close. Yeah.
Right. So if you look at one of those scales, what they will say is first degree relative with breast cancer. Right. Okay. Mother, sister, daughter, that kind of thing. Brother, father.
Right.
Yeah. So you really have to, if you think you're at risk, you really need to see a clinician about it.
Okay. It's funny, I never thought I was at risk because my mom didn't have it and my grandparents didn't have it. And I had a very small family. Like my father didn't have brothers and sisters. My mother had one brother who never had a kid. So I had a small family, and they were of the generation where people died in their 60s. And so I met some of them, but I never met my father's parents or anything. And as I got older, And now I am going through menopause. And then I think I told you that when I was cleaning out my father's house, I found a drawing that he had done of his mother, years later, like maybe 2 years ago before he passed away, or actually 4 years ago, saying that a picture of his mom before the mastectomy. He
and
never
you didn't even know.
He had never mentioned that to me. Like he never thought that was important to know. So now I know it's not a first degree. That's a second degree.
That's a second degree. But what did your dad have? Did he ever have prostate cancer?
No. Parkinson's is the only thing he got.
Okay. If he had had prostate cancer, then you'd be considered with possible 2 risks there, because prostate and breast both have a sign for the BRCA1 and 2 gene. Wow. So that puts you into a whole nother place. So that's why I'm saying to see somebody, if you have any risk factors, go talk to them, talk to your family. Yeah. I cannot tell you how many women come into me and say, well, I don't think anybody ever had breast cancer, but I've been alienated from my mother for 20 years. Well, you better find out, because it's, important.
And there's also the people who are very close to their family, or they call it close, but they never talk about
That's
stuff.
exactly right. That's right.
There's that. And I've got a family who talks all the time, but I still didn't know. And also my mother had lung cancer. I know that lung and breast cancer are the 2 highest risk cancers.
That's right. But
are they connected?
No.
Okay.
Lung cancer is almost always exposure. Okay, almost always. It's second degree smoke, first degree smoke, exposure of some asbestos material, whatever.
Right.
Lung, it's very different. And it is just as high as breast, but breast is the highest in women.
Isn't that terrible?
For the women's disease. Over 200,000 women a year are diagnosed.
Okay, so I'm going to backtrack, because you talked about being perimenopausal and menopausal and being diagnosed either before or after.
Right.
So let's say that somebody's mother was diagnosed at 34. So, right. So that's, perimenopausal still. So what happens there with her first degree daughters? What's their risk? When does that begin?
Okay. So 34 is premenopausal.
Right.
It's not perimenopausal. I'm going to let me, so this is kind of the myth stuff that we're talking about. Thank you. So it's okay. So when you start having symptoms of menopause, you miss a period, you start having hot flashes, you could be 34, but that would be pretty young to have it.
Right.
But you're probably going to be, the average menopause is between 45 and 50, but it can go on and on and on, as we know, right?
Yeah, we do.
I had hot flashes forever. And so premenopausal at 34, that is a high risk. That's higher than a postmenopausal, because when you are young and you get it, it tends to be a more virulent cancer. Not always, but it does tend to be.
And do you get it, does the risk go up in your 60s? You said 62, I think, is the
average.
Right? Is the average. So does that happen just because everything starts to slow down as we get older? Like, is that like just part of that? Or is it something in the breast tissue that happens at about that time?
It has a whole lot to do with just being a female. And the number of menstruating cycles that you have something to do with your risk for breast cancer. For example, if you start menstruating at 10 and you go through menopause at 55, you have a lot of years that you're menstruating in there. Okay. Right. So that's a higher risk. Now, is it a big risk? It's one of all those risks I was telling you about. Right. Yeah. It's
really more about how many risks you have, not if you have a risk.
That's exactly right. But a 34-year-old mother, I would definitely be seeing a geneticist.
Okay, wait a minute. Why does the more periods you have make you more susceptible?
Because it's the more times you ovulate. And the more times you ovulate, the more times your breasts are involved in hormone production. So it's that whole cycle.
The ebb and the flow of the hormone stuff?
That's right. And I'm sure you've heard this before too. People say, well, if I had a baby younger, does that mean that I cut my risk? Well, statistically, that's another risk. If you had a baby, it used to be over 35. I think they've moved it to 40 now because so many people have babies over 35.
Yeah.
But your first baby, if you have it over 35, that means you've had that many more cycles before you interrupted all that ovulation. Yeah.
Okay, so let me ask you a totally selfish question, and this may not apply to anybody else watching.
Okay.
But I have polycystic ovaries, so I never got periods. I never got periods. I was on the
Right.
pill though, but like, and I never, so am I better off? Is that one less risk for me? Because I never ovulated? I don't ovulate.
Yes, that's true.
Woohoo!
It does, right. But then you have other risk factors, I would imagine.
Right.
You know,
Well,
and
we've
I'm not
discussed
going to,
them.
right, exactly. And
Yeah.
because women with polycystic ovarian disease, as a rule, do not ovulate either. Okay. Now, so, and if they do, you don't know when, right?
Right. Yeah.
So a lot of those women have done infertility. Okay. And well, I wasn't going to say that,
Yeah,
but
it's okay.
you know,
I'm open.
We're very transparent here.
Yes, we are.
So ironically, if statistically and scientifically, if you have done any fertility work, especially just a couple, you're not at higher risk for breast cancer. But I see so many women come in that have been through infertility, because how can you not have a little bit higher risk when you're, kind of making your ovaries go up and down like that, and you're taking injections and you're taking hormones? But scientifically, no risk. Isn't that interesting?
Yeah, it is interesting, because I did have help, and I took the hormones, and then I was inseminated. But in between that time, I got 35 eggs.
Yeah, well, see, that doesn't mean you can't have eggs, because you have polycystic ovarian
Right.
syndrome.
No, when you take the
Obviously.
hormones, you make them ovulate, and they grow.
Exactly.
But the amount of eggs, does that have anything to do? Because if it's not, okay, all right. So
not the amount of eggs.
All right,
it's the number of times you go through a cycle.
Okay, so I'm one less risk.
Yes, there you go.
All right, so as long as we're talking about myths and stuff, there's the Underwire Bra Myth, there's the antiperspirant myth or not myth, there's the hormone myth or not myth, hormone replacement therapy, and I'm not sure that that's all in the same group as far as myths go, because there's some science behind some of it, and also some science that just says, it's just such a small thing that we don't really worry about it. So I don't know how you want to attack everything I just asked you, but I'm going to let you do it, because I'm sure you've been asked that question before.
Many times.
Yeah.
Okay, so let's start with Underwire Bras. The reason Underwire Bras were brought into I guess, example is because women were getting marks underneath their breasts that would be sort of like lumps. Okay, that didn't mean they were necessarily cancer, but they were irritating women's breasts. So scientifically, it is a myth. Absolutely, they do not have any really good resources that indicate that that's a problem.
Right.
And deodorant, it's always good to use things without, it's parabens, I think, or paraffins, parabens, I think.
And aluminum.
And aluminum. It all kind of goes together. But that's a general health situation. The theory was that if you used certain antiperspirants, that it would go into your arm, under your arm, into your lymph nodes, and probably cause breast cancer. Again, there's no science in this at all. And I looked it up before I came on this show.
Because we talked about it.
We talked about it,
Yeah.
right? Because, I get this question all the time, and I always answer the same way, which is there's no scientific data. It's a lot of myth.
Do you wear antiperspirant with aluminum in it?
You know what? I don't even know.
Okay.
I wear 24-hour Avon. I hope that's not a commercial, but I do it because I'm a nurse practitioner and I sweat a lot, and I don't want and I already had breast cancer.
Right. Listen, I wear the non-aluminum, just the deodorant, not the antiperspirant, when I'm wearing a shirt like this or whatever. But if I'm going to wear a long sleeve shirt and I'm doing hair, you can bet your butt I am putting on antiperspirant.
Exactly.
Because how gross would it be for me to have big sweat?
I know.
All right. So I'm glad to hear you say that, because I understand that there are risks in everything. You walk outside, you could get hit by a car, but is it something that you should worry about doing once in a while? Go ahead, girls. Protect your clothing.
Yeah, exactly. It's
Okay.
not.
Let's talk about HRT.
Okay. Now that's a whole thing of a different color, because that is not a myth. It depends on who you talk to, which scientist, and how long you can take it before you put yourself into a risk factor. Now, when I was diagnosed with breast cancer, I was on hormones. I have no family history, had babies young, wasn't particularly overweight, didn't have any of the other risk factors that you might think of. Do I question whether or not that was an issue? Of course I do. Do I know the answer to that? No, I don't. All right. I don't take hormones anymore. Theoretically, the science that appears to have been proven is that women that take hormones have a higher risk than women who don't.
So were you on bioidenticals, or were you on like what was it? What were they made of?
This is my favorite subject.
Okay.
Okay. Your body doesn't know the difference between bioidentical and synthetic. Okay. So you're going to rev up your ovaries or rev them down or whatever it is you're going to do. Your body doesn't know the difference.
Just knows it's being revved up.
Exactly. I mean, if I could tell you how many women come in and say to me, but I was on bioidentical. It doesn't matter. You're changing the milieu of your body that's natural. Am I a non-believer in hormones? No, I'm not a non-believer, because I believe that some women absolutely need hormones. They really do. Some women truly crash during menopause, and it's all individual.
And we talked about that, and you supported me using it, because I think I may have mentioned this before on my menopause one, but in case you guys missed that, I'm a pretty upbeat human being, and I literally had like a week of doom and gloom. Now, it was during COVID, and so I'm not sure how much of that played into it, but COVID's been going on for a long time, and it sort of happened right after I went off the pill, that doom and gloom. The sweats were incredible for me, and also the joint pain, like my knees and my neck. I thought I had arthritis all of a sudden, and now I've been on them for about 3 months, and my quality of life is better. And that's when you said to me, then you should be on them.
Exactly. Because now, if you would have said to me, I have 3 sisters and a mother, and my grandfather had breast cancer, I would be trying to talk you out of it. I really would.
Right.
Because I have a whole list of things that you can take that will eliminate hot flashes and the arthritic symptoms and that sort of thing that you can take that are natural. But I have seen so many women get so much better on hormones. In fact, if you said to me, if I go on hormones, am I going to feel better? I'm going to say, yeah, you are. You are absolutely going to feel better. But you have to weigh your risk.
Right. Is it worth the reward?
Yeah, exactly. And with some women, it is.
Yeah, well, for me it was so far, but I'm not on it for 10 years either. So your list of things that you can give people that are natural, is that something that we can talk about quickly, or is there a place that you can send somebody, or is it in your book that we talked about? Where can we get that?
No, my book is old, and the irony of that book is that I was writing it when I got breast cancer.
Yeah.
It was so weird. Because I put an addendum at the very end of the book, and I said, ironically, I've been diagnosed too. So we didn't really it was a long, long time ago, 20 years ago that I wrote that book. And I haven't really written since, except in journal articles. And I lost the train of, what were we talking about?
I was asking you about...
Speaking of menopause.
Yeah, right. Speaking of brain foggy stuff.
Yeah, right.
I was asking you about the list of things that people can do if they choose not to go on hormones, like the natural supplements, I guess you're talking about. I mean,
I have a whole list of them, and I could send them to you, Nikki. But they're things like bioflavonoids, which are natural and natural vitamin C. If you take more of those, you could get less hot flashes. But what I do is I work individually with everybody.
Okay.
That's part of what I do as my job, is that we sit down and because if you take everything at once, you're not going to know what's going to help. So you have to go through a series of things.
Right.
So it's a bit of a long list.
Okay, so you need to ask the person you're dealing with. But talking
Absolutely.
about bioflavonoids, did I say that right?
Bioflavonoids, right?
What was the Lucille Ball thing? The Aunt Jemima Vita Vija Vitamin. That's
right. Oh God! I can't believe you remember that.
Well, so those things we just talked about, those BF things. There are things we can do to lower our risks, right?
Yes.
Tell me about those.
Okay, so let me see. Where do I want to start here? First of all, I believe that every woman should be seen by a breast health specialist. That's just me, okay? Gynecologists are fine, but I was in gynecology, and I remember the way I used to do a breast exam, and it was not okay. All right. It wasn't something we focused on. We focused on below the waist. That's just that simple, or a pregnancy or something like that. So we weren't really paying that much attention. I think it's better now, because breast cancer is so much more open than it used to be, and people talk about it. And I think that the residents and fellows and medical students are taught better than they used to be. But having a breast exam is important from the time really that you're sexually active, I think. I don't mean 13, or if you're God forbid your kid's active at 13, but I mean, probably in your early 20s, you should be having breast exams, and you should somewhat be familiar with your own breasts. Now, those shower cards that you saw years ago, all those things, they really didn't teach very well, and they scared people.
Yeah.
So my theory is that you become familiar with your own breast tissue. You know where you've got your spots, and you go over them with your clinician. You go, oh, I have a little thing here. What is that? They might check for it. They might not, but know the changes in your breast. That's how I found mine.
Yeah, know them so that you know when something changes.
Exactly. And you always check yourself 7 to 10 days after the first day of your cycle. If you're postmenopausal, just pick the same day every month.
So where were you when you found yours? What happened?
I was doing a breast exam in front of the TV, and I found this like little pebble in my breast, and I thought, that's weird. So I went to my husband and I said, can you feel this, please? And it jumped back like that. And so I thought, my own doctor didn't think it was a breast cancer either. And so I had a biopsy because it didn't show up on imaging, didn't show up on mammo, didn't show up on ultrasound, didn't show up on MRI.
It sure would have a year later, though.
You bet your ass. Excuse my language.
That's okay.
You bet. It could have been breast cancer as a rule is a slow growing disease. There are a few kinds of breast cancers that aren't slow growing. Mm-hmm. You know, there's 60 kinds of breast cancer, right?
Oh my God, no. But I mean, of course, that explains why there's no one answer fits all.
That's exactly right. And it's so different in every single case.
Yeah.
And, I'll have women call me and say, you know what, my friend had the same thing I did, and she had to have chemo. Why didn't I have to have chemo? And sure enough, what I'll find out later is that they had a biomarker that she didn't have on her cancer, right, which made it totally different than their friend's cancer. So right, that's another myth. They're not all the same.
Right. And you were talking about finding the lump. Oh my God, now I just lost my train of thought.
That's all right. I sidetracked there.
Okay. So we're talking about the things you can do to lower your risk. Oh, I know what I was going to say. So when you decided to get your biopsy, whose decision, who told you to do that? I mean, you were in the world. So was that just something you thought, I'm doing this? How did that happen?
No. If it had shown up on imaging, they could have sampled the area under imaging, either through ultrasound or mammogram, and even MRI at that point. But there was nothing to see, but there was something to feel. So This is a great lesson for all women. If you feel something and it doesn't show up on imaging, you need to have it sampled, right? And mine was small enough, they just took it out. So I get this phone call on the way to the aquarium with 2 of my grandchildren saying, Sherry, you're not going to believe this, but you have breast cancer. And I just kept right on going to the aquarium with my grandchildren.
Now, is that because you know so much about it and you weren't so nervous? Because you've been around it so long?
I think so. Yeah, I think so. And I'm not a very nervous type anyway about those kind of things. I mean, I suppose, when my husband got throat cancer, I was damn nervous, but really scary. But this didn't scare me. I knew I was going to be okay. What bothered me more is what the treatment was going to be. Was I going to have chemo? Was I going to have radiation? What was I going to do? Were I going to take those pills? And those are the decisions that every single woman has to make when she's diagnosed.
And do they give you choices, or does somebody... how do you decide what to do? Okay,
so everything is about the biology of the tumor. It's like a cake. You have 20 ingredients, right? Tumors will have like 20 ingredients. And if you take 5 of those ingredients and you add them all up, then you may buy chemotherapy.
I see.
Or, I could name them all for you, but it's too scientific.
It'd be over our heads. But like you said, the 2 people that you spoke, your clients or your friends who had the same kind of breast cancer, but no, because there were different markers. So
exactly.
The treatment is different. So it's not something that we decide. Like They don't say, do you want chemo or just radiation?
No, and that's a problem because women today are very, very proactive. And many of them think, I'm not doing radiation. I know what it does. It burns your skin. Or I'm not doing chemo. It kills all the cells. It's got to be a real discussion with your provider because there are real reasons to have chemotherapy, and certain kinds of cancers are going to come back, and that's a problem.
Yeah, geez.
So it's really not up to us, but some women will make it up to them.
So,
and I really discourage that.
Yeah. Okay, so you're somebody who gets diagnosed, but you know about it. It's in your world. You know you can go to work the next day after your grandchildren and be taken care of, and you'll be fine. And you've been around it. You've seen people thrive and survive and all that. So somebody who isn't as lucky as you to be immersed in it like you are and is comfortable around it gets that phone call. Like, what's the first question I should ask? What are the first 3 questions you should ask? Obviously not all of them, but like right away.
You mean once you're diagnosed?
Yeah, if somebody calls me and gives me that, or calls me in and tells me that, like, what am I supposed to ask immediately? What do I need to know?
You need to go see your person who died, a breast surgeon immediately.
Okay.
Okay. Now that doesn't mean you're going to have surgery first. Okay. But that's the first place you go, is to a breast center and to a breast surgeon, or a nurse practitioner even. Okay. Because that's what we do at the breast center. We then, if you're already diagnosed, you're going to see a surgeon. If you're still thinking you might be going to be diagnosed, you just get a workup, like with mammogram and an ultrasound, things like that.
Right.
But the first question that you want to answer is, please inform me of exactly what this means. Not, am I going to die? Am I going to, I just want it out. I don't want chemo. You just listen for a while, take it in, and get to opinions.
And bring somebody with you to
absolutely bring somebody with you, and have them. If you can't because of COVID, which we've been running into,
can you
bring a tape recorder, or you can have somebody on FaceTime.
Yeah, because I'm sure all you it must be all you hear.
You don't hear a thing.
Yeah.
I mean, one of the things whenever we build programs is we try not to say too much when someone's newly diagnosed, because they're not going to take it in at all. As soon as you say you have breast cancer, I hate doing it over the phone, but I have to tell you, many of my patients ask for that because they don't want to come back in if they don't have to.
Right.
The doctor I work with, he will not diagnose over the phone. You come back in to get your results. And he has his reasons, and I understand them. Right. But if I'm dealing with a woman that's working in childcare and on and on and on, and they say, will you just call me? Then I will.
Right.
And it's different for every single person, because some are just freaked out and others are totally fine. But
I understand the idea that it's more comforting to be with somebody when you're hearing that kind of news. On the other hand, there are those women who are just splitting their time too much, and they don't have the time to come in and find out they're fine.
That's exactly right.
Yeah. And not to mention the dreaded drive there knowing you're not fine.
Exactly. I mean, it's dreaded enough time to get a result on a mammogram, and hopefully you go to a place where you can get it the same day. It doesn't always work out like that.
Right.
But for women who've had breast cancer and then they come in for imaging, what happens is that they wait sometimes 45 minutes, an hour, and then they might be called back. We might want to look a little bit more at your imaging, and your heart's going 100 miles an hour. And I really recommend meditation when you're in situations like that.
Boy, meditation
Lots
is
of
good
deep
for
breaths.
everything. Yeah. So I shake my head as a knowing shake, but not, thank God, because I've not been diagnosed. But if you couldn't believe that my 34 double A's are high risk for some reasons, and I have dense breast tissue. And so as I've gotten older, and I guess more tests have become available, I would assume that's what happened. I got that first letter about the fact that I had breast dense.
Dense breasts.
Thank you. Say that 3 times fast. That thing. No one had ever told me that before. Well, then I found out it's not that no one could told you, it's that we didn't see it so well. So then I started getting the 3D mammogram, and then something happened where I needed an ultrasound. And now, because I'm menopausal, because I'm in menopause, I'm past menopause. I don't know what do you call that? What am I?
You're peri.
I'm perimenopause. That's right.
All right. Okay. Postmenopausal is you haven't had a period for 1 full year.
Okay. Then you get into menopause.
That's postmenopause.
Right.
Perimenopause is when you're going through it. You're missing a period here, you're missing a period there, you're getting hot flashes. That's all peri. And that can go on for 3-4 years before you miss a period for a full year.
Right. Okay, so I am post-menopause.
You've missed it for over a year.
Yeah. And so now I'm getting the ultrasound. And I remember the first time that happened, where I went and had my 3D, then I had the ultrasound. The lady finished and she said, I'll be right back. And then she came back and she said, the radiologist is looking at it. He'll be in soon. And I was like, oh, should I go change? And she said, no, just stay here. And I thought,
that's so scary.
It was horrifying. And, she didn't have the wherewithal to say to me, this is our protocol. We have you wait here just in case he wants to do it again. And of course he came in and the first thing he said was, "Nikki, you're totally fine. There's nothing wrong.
Yeah.
I just wanted to look at it again. And we always ask you to wait in your robe in case we want to go back in and do it again. I can just put you back up on the table and do it." Well, somebody should tell people that before they go in.
Absolutely. That's a big problem. And one of the problems is technicians are not allowed to give results.
Right.
So they walk a tight line. And every once in a while, you get a technician that sees the real anxiety in a patient. And she'll tell them, you're okay. We just need to do some tests. But I've also had them tell it wrong. So it's really a difficult situation, but the way you just presented it is exactly the way it should be presented. Way beforehand, if we call you back, it doesn't mean you have breast cancer. If we keep you in your robe, it means because we might want to take further views. That doesn't always allay their fears, but it does a little better than what happened to you.
But you know what else we can do? We can advocate for ourselves when we go in and we can say, what do I need to know before I go in?
Yes.
Before I go in, so I don't lose my mind. Like, what's going to happen? Tell me everything I should expect.
Absolutely.
So ladies, ask. Be an advocate for yourself and ask.
Yeah.
It's never bad to ask a billion questions. No one's ever going to shut you up at a breast center for asking questions, right?
Well, it depends on who you talk to. No, I'm kidding. But truthfully, that's correct.
Yeah.
I mean, some questions will appear redundant to people like us. It's never redundant to the patient.
Right.
And you have to listen to your patient. You absolutely do. People get busy. People want to move patients along and they forget about things like that.
Yeah.
So it's kind of up to the patient to say, okay, I'm going to take a deep breath and I'm going to find one person that I think might talk to me and just say, okay, here's what's happening. Can you just have my clinician sort of explain a little bit? I think they respond very well to something like that.
Yeah. Can you talk me off the ledge, please? I feel like I'm dying right here.
Exactly. Anybody says that to me and I'm right there on the ledge with them,
Yeah, right? Yeah.
And
the other thing to do is, I know a lot of women are uncomfortable talking about women's health. I don't understand it because it's not me. But at my work, which is why I'm doing this, is because standing behind the chair as a hairdresser, people asked me everything and people told me everything. So I shared the knowledge. So like when I talk to people about mammograms, I tell everybody that happened to me so that now they know that if it happens to them. So if it happens to you, spread the word just so that you can save people from freaking out about stuff.
Well, but there's a lot of people. Well, you're talking about diagnosis of breast cancer, or are you talking about what happened as your experience?
Just my experience, having to go, get one more test and waiting and sitting in your robe. And because it's enough to make you you get home and you're wasted because you've just had a miserable experience. I'm like you, transparency is really important, but everybody has a different personality. And there are a lot of people who go right up on that ledge, as you know. It's just the way it is. I had a friend recently who had one abnormal lab test. And because she had serious breast cancer, that she'd been what I consider to be a thriver, a big thriver, and her numbers were up just a teeny bit, she went right to that ledge, right to the ledge. Because she'd been there before.
She'd been there before, but now this was post her diagnosis. So it was like, is it somewhere else?
Oh, God.
And, only one marker is usually not going to be the answer. But if you have a good clinician, they're going to work it up. But that scares you,
Yeah.
It's a tough one.
The label is terrifying.
Yeah, it is. And by the way, different cultures handle it different ways too. Like you were saying that a lot of people don't like to talk about women's health. You find this much more in, it doesn't matter which cultures. There's just some cultures. I just encourage all women to talk to each other, period.
Absolutely.
It doesn't matter. We're all in the same boat,
We all have boobs, breasts.
We all have boobs.
It's and I, you and I sitting in my chair. I might have been done with your hair for an hour, but we'd stay there talking because we just love to talk and share.
Right, so exactly.
We started to talk about things you can do to lower your risk, things you
can
do,
your risk.
Things you can,
All right. So generally being healthy is very important with breast cancer, okay? Diet, exercise, staying hydrated. If you asked me what the one thing I thought would really help women to stay healthy in all areas would be, I would say move around a lot. I'm not even going to say exercise, because I don't want anybody to go out there and start, hurting themselves. But something you do every day for 20 minutes is going to make a difference in your life. It really is. And if you increase it to a half hour, an hour, it will. It doesn't matter what it is. Even if you're cooking and you're dancing on the floor, whatever, stay moving.
Stay active.
Yeah, because things tend to just sort of get stuck in the body. And who knows? I mean, I'm not suggesting that that's how you get cancer at all.
Right.
But in general, I mean, good diet. There's a lot of new data on alcohol. And if you drink more than, so let me tell you the study. They did a study on 600 women. They drew their blood before they drank 1 ounce of vodka. 2 hours later, they drew their blood and their hormones had gone up 200%, their estrogen levels. Okay.
Wow.
I know. So if you try to make a conclusion from that study, I've known about this study for a very long time. I think the real answer is don't chug your drinks. Drink them slowly, and don't, put your body under stress of, liver and hormones and whatever is going on there. It's that kind of drinking, I think, that's a problem.
Sure.
They say 1 drink a day is not a problem. You probably ought to go to 2 or 3 a week. I mean,
it's still 6. That's 7 glasses. 7. I can't even count.
Glasses.
Still 7 drinks a week.
Right, but if you have that much wine as opposed to that much wine, and you drink it slowly, it's a whole different ballgame.
Interesting. And so it's just the faster you drink it, the faster your hormones rise?
Well, according to that study, that's how it went, because it was a big chug of alcohol and boom, these hormones went sky high.
Wow.
Yeah. So there's a lot of studies about alcohol, and some of them nullify others. Like they will say, red wine is really good to have 1 every day. But then you think, okay, now wait a minute, there's alcohol in red wine. Why is that any different than, a shot of vodka, right? Exactly.
So are there studies with marijuana now that marijuana is legal in so many places? I have
not seen any in terms of breast, but I am working on it. Okay. Because I think I told you, I just had a knee replacement and I used some marijuana to combat my pain, and it was great. And I'm now starting to talk to my patients a little bit about things that they're going through, because we now have medical consultants that are talking about marijuana, and I can refer them to them.
My doctor had me, I wouldn't smoke because I grew up with serious potheads in my house, and it always freaked me out. Yeah. I mean, my parents they were stoners. And my whole house in the 70s smelled like bong water with the shag carpet and everything. So smoking is just nothing I wanted to do. But when I was really stressed out, when my kids went to college and my father was getting ill, my doctor was like, Nikki, I'd like you to start having edibles because you're too stressed out. And I can vouch for the fact that, boy, does it help.
I am so glad your doctor did that, because you don't find a lot of doctors like that.
I am so grateful. And I remember I came home.
Really?
I was driving home and I said to Randy, so I'm leaving, and the doctor suggested that he gave me a medical license to get pot. And Randy said, get it! And I was like, but I don't know, my parents were stoners, and get it! And
it's edibles are different. And you're right. I don't like to do the smoke either at all.
Yeah.
But it does help. And it's a whole lot better for you than a Valium, and a whole lot better for you than a Xanax. Yeah. And, I think it's going to be the wave of the future. It already is, really. Yeah. I mean, there's a lot going on. I mean, I was in a MedVent store yesterday, and there's a medical consultant in there now.
I love that.
Yeah, I do too.
It is just so helpful. I mean, it is just so helpful. Okay, I think we've covered pretty much everything that we wanted to highlight. Is there anything that you can think of that I didn't ask you about that you want to make a point about and make sure people know?
Yes. One thing that kind of rang in my head when you gave it to me as a question, even though we didn't deal with it head on. Imaging. Okay.
Yes.
So
right.
Okay. So when it used to be that they said at 35 and up, you should be getting mammograms. All right. Well, they've increased that age, and for someone who has no risk factors, they're saying 40 or over now. Yeah. Right. Exactly.
And then every other year.
And every other year. Now, I belong to an organization who is really, really, this is the one I'm being honored by, the National Breast Cancer Coalition, really into science and facts. So if you asked the question, does mammogram save lives? What do you think the answer is?
Not alone.
Good girl.
Okay.
Not alone.
Yeah.
That's exactly right.
Yay.
That really, because most people think it does. And mammogram only detects about 80%, if that.
And the one you
right?
had couldn't be seen.
Good. That's why I told you my story, because
Yeah.
I could not be seen. And there are those that can't be seen.
Yeah.
So when a woman says to me, I only want ultrasounds, I don't want a mammogram, my reaction to that is mammogram is still the gold standard because you can see the most. And now that we have 3D, you can see the most. Okay, now I want to talk about your dense breasts for 1 minute. The reason dense breast tissue is considered to be a higher risk for breast cancer is why, Nikki?
Because you can't see through it. The tissue's too dense.
Right. It's not because the tissue itself is creating you to be at risk for breast cancer, it's because you can't see through it.
Right.
So we have now 3-dimensional mammogram and 3-dimensional ultrasound. Now, is everybody a candidate for that? No, not at all. And some women will come in and say, I want a mammogram, I want an ultrasound, I want an MRI, I want everything you can do. That's not the way it works.
Mm-hmm.
It works. First of all, MRIs can be way oversensitive. So if you went straight to an MRI, you're going to end up in biopsy.
Oh.
Okay, in many occasions. It's a real puzzle the way this works, because coming in for a mammogram, if you have a normal mammogram and a normal physical exam, are you 100% guaranteed you're going to be fine till next year? Of course not. Mm-hmm. No. But if you have those risk factors that I was talking about, then you're likely to come in to see your clinician twice a year. And then you may add another kind of test to it. But it isn't cut and dry that one thing is better than the other. It's still mammography is the gold standard.
The gold standard, but it doesn't do it can't do everything. Can't find everything.
No.
And you said something interesting to me when we talked last week about the fact that I get the ultrasound and the mammogram when I go. And this is really important, guys, because I called my breast center and I changed my appointment after I spoke to Sherry. And Sherry suggested that I get the ultrasound in January and my mammogram in June, so that I'm having my breasts checked visually twice a year, not just once a year, because so much can happen in a year. Yeah, even though it grows slowly, still.
Right. And insurance will not allow you to do mammogram twice a year and ultrasound twice a year. So if you do it together, you're right. You have a whole year. That's right.
Okay. So speaking of insurance and what they'll pay for, are these newer tests available to everybody? Are they too expensive for some people? Or is
it all depends on your insurance company. Everything is about insurance. You're right. There are programs for people, and usually they're with individual hospitals or individual breast centers, that they will help underprivileged people.
Okay.
And, Obamacare, as much as people don't like it, it was a saint when it came to helping people get lower cost insurance so that they could get mammograms. California is pretty good about getting, if in certain times of the year, they will help women get free mammograms. But it's important to know what your provider allows, because, for example, when a woman gets breast cancer, one of the first things we do once we find it is to do an MRI if they haven't had one already. And the reason is we're looking for something in the other breast or that maybe mammogram didn't see, making sure that they're not dealing with it on both sides.
Right.
I cannot tell you how many insurance companies try to fight that. And it is outrageous. We have to get on the phone. We have to talk peer to peer to the insurance companies. It's very difficult. So there's no answer for this, Nikki, unfortunately, because it depends on your insurance, it depends on your coverage, and it depends upon, how many times you've had it that year, how old you are. There's just so many variables.
Okay, so you may not be able to answer this question, but what happens if somebody's diagnosed, they need an MRI, and the insurance company says no, and you make those phone calls and they still say no? Does that happen?
Yes, it does happen. Usually where I work, it doesn't, because my particular institution is reputable, and we have sharp people that get on the phone and that sort of thing. Once diagnosed, they almost always will do an MRI. But in terms of a high risk woman who she has 2 family members that have breast cancer and she maybe is positive for the BRCA gene, will the MRI always be approved? No, We have to really push for it. So yeah, a lot of times you have to just really fight your insurance company. And I've had a lot of women win.
Yeah. I'm a winner. I've definitely gone to task with my insurance company and all sorts of
Good.
people who try to take advantage of whatever situations they can. And again, I say be an advocate for yourself, ladies, especially with your insurance
Always.
companies.
Always.
You know, there are rules. And then recently I was trying to get something done, and the person, I kept being turned down. And the person I spoke to like the 19th time was a type 1 diabetic. And she was like, you know what? I know where the loophole is for this.
Oh my gosh. You see? And verbiage is important. What I write on an order very often will make or break the deal. But you have to know what the verbiage is, and it changes every year.
Yeah, that's the other thing. It's just so hard for everybody to keep up with.
I know.
I don't know what came first, certain places charging too much or insurance companies paying less, but whatever it is, it's an ongoing stress factor.
Yeah.
And I'm going to say it, and then I want you to say it the medical way. As a woman who is not afraid to ask anything or stand up for myself or put anybody in their place, I say ask every question and fight for your rights.
Absolutely.
But as a
100%.
doctor, as a nurse practitioner, how do you say that to people who aren't as confident? Is that the good word as I am? I don't really know if that's not the best word for it, but who aren't as willing to stand up to people as I am. How do you talk people into doing that when they're...
You mean if they're my patient?
Yeah.
Or people that are listening?
Yeah.
I think if you have children, it's automatic that you advocate for your children. Okay. People don't do that as well for themselves as they do to people they love. They really don't. You have to love yourself, and you have to want to be there for yourself. Are there people that are over the top? Sure, there are many people. But you know what? When it comes to breast cancer, ask everything you want to know. Everything you want to know. Write it down. Try and get it the first. I mean, if you don't get it the first time, ask the second time. Mm-hmm. But that's what we're there for. That's why we have so many people that are working in this field. Yeah. Is because we get it. We do get it. Yeah.
This information filled, and maybe we'll do it again in a couple of weeks if you come across a new finding about marijuana or something else that you want to talk about, or even later in the year or the next year, because number one, I love talking to you. Number two, you're so knowledgeable. And the fact that you are a thriver. I think it just makes this conversation even more important for people to listen to, because we're not guessing here. We're talking about experience.
Yeah. And science is really important, ladies, really important. And let's just for 1 second remember that men do get breast cancer.
Please.
They don't get mammograms, obviously, but
how do they know? How do they know when they have breast cancer?
I'm going to tell you.
Yeah.
So I get men a lot come in with swollen breasts, one or the other. And the very first question I ask them is if they're using marijuana, because that will cause a lump in your breast. Okay, it can. So if they have a lump and it's not on the other side, they're going to get a mammogram. Mm-hmm. All right. But if any man has a lump around their nipple, they need to be checked.
And men should also know their breast tissue.
Absolutely. And they usually do. Oh, I think they do.
You think they do?
I think they do. And if they feel a lump, they know it. They do. Because sometimes in men, because they're so flat, you can see it. So they have to pay attention to that. Yeah.
Right. All right. Yeah. So men, if you don't know your breast tissue, and we're not talking about your wife's breast tissue.
Right.
Your breast tissue, the one in your body, get to know it. And does their risk go up as they get older as well? Is that the same?
Yes, but usually their risks are higher with family history too. Mm-hmm. Yeah, but there are plenty of men I've had that have had nothing. Who knows why?
That's great. Okay, so one more thing I'm going to add to this. I also am going to get a BRCA test, which I've never had before, because I spoke to Sherry. So if you haven't had it, and there's somebody in your family who has it, who's a first-degree relative, please get the BRCA test, right? And yes. Nobody suggested that. My endo hasn't suggested that. No gynecologist I've ever had has ever suggested that. Never.
You're talking because of your grandmother, right?
Yes.
Yeah. And insurance does play a little bit of a part in this. So what I would do, Nikki, if I were you, I would talk to a geneticist first.
Okay.
And tell them your history and see if you're Ashkenazi too, aren't you?
Yeah.
Okay. Those two things your insurance may cover you because your grandmother had breast cancer and you're Ashkenazi.
Okay.
If you have to pay for this, I'm going to tell all these ladies this. and your insurance won't cover it, there are places that'll do it for $100, $150. Ask for it.
Okay. Who do you
because
ask?
you ask your clinician, they'll know how to do it.
So are you my clinician?
I'll be your clinician.
Okay. Okay. So I should come see you, and then you'll write me a thing for the bra routine?
Absolutely.
Okay. I'll plan to do that when I'm back in town next week or whenever you have time.
All right.
Well, I got to see you here. I'll get to see you there. You get to feel my boobies, and this is going to be fun.
Great to see you, Nikki.
You too, Sherry. Thank you so much for your time.
You're
really,
so welcome.
I just adore you. Thank you so much.
I adore you too.
Okay.
Take good care.
You
Bye,
too.
Nick.
Bye.